Hi, I'm Dr. Marie Rudback, and I am a chiropractor here in town. And I took a little bit of Carrie's advice in how to address everything, but I just felt like perhaps you might not know what I do in my office. So this is going to be more of a basic overview of what you as a patient or what your patients might expect having come to a chiropractor's office. And granted that the art of chiropractic has a lot of different interpretations, and I'm kind of a no-nonsense musculoskeletal neuro adjustment. I don't do a lot of anything else that my entire panel does, since there are so many qualified individuals in town that I send my patients to. So let's see if I can try to use, I am a member of the Pain Standards Task Force, so I am a board member of everyone who's organized. Thank you, Carrie, so much for organizing this panel. So welcome to our event. So chiropractors in Oregon, every state is regulated, but in Oregon we have a very wide scope of practice. So as the art of chiropractic is interpreted, we can do a lot of things. And I have chosen in my practice to be fairly narrow, as we do have many qualified people in our town. I don't need to do everything. I do not need to do proctological exams. I do not need to deliver babies. Those are within the purview with certifications of chiropractors in Oregon. Who knew that? So the top few are going to be chiropractic manipulative therapy, using our hands to adjust a patient's soft tissue mobilization, not the same as massage. So this is going to be more of a targeted trigger point therapy, something more akin to what Allison does in her office. There are other adjunctive therapies, just like a physical therapist or massage might use as well. We've got heat and cold, ultrasound taping, the cold laser is very popular, electric stim, lots of different things we can use here in Oregon. As I mentioned, the approaches can be varied. There are lots of specific techniques, so if you have heard of one or others that might be beneficial, no, Webster is not for turning breech babies. However, it is beneficial for pregnant women. Craniosacral, great for some upper neuro issues, concussions. Activator technique, it uses different tools. Diversified is what I use, a little bit of everything. So there's lots of different ways to be a chiropractor in Oregon, which is pretty fun. You go to Washington and you can do two things. So it's very different in every state. So patient education. I do a lot of this in my office. I clarify a lot of misunderstandings about pain, acute versus chronic, what actually is pain versus a stretch. Shouldn't be painful, but patients sometimes are so overwhelmed in their chronic pain that everything hurts. What doesn't hurt, doc? We heard that this morning, and I appreciate Eric's presentation earlier this morning with a lot of neuro in there, so I'm really glad that was brought up already today. Patients really need to understand that in a chiropractor's office, it can be a treatment that can be ongoing. It might take a little bit of time to make a difference, but at some point, the care should turn from passive to active. And in my office, I give them 2 to 3 visits really, and to see if they're willing to participate in their care. If they just want to come in and get cracked every week for the rest of their life, they're not an ideal candidate for therapy in my office. So I really focus on self-management strategies, which are something that is also part of the Living Well program. Patients learning a lot of ways that they can be in control of their recovery and understanding what expectations are. Being in no pain versus pain all the time is something that patients need to really tease out when they're thinking about what are your goals in treatment. Another thing that I work with a lot is ergonomics. People don't know that everything they do is bad. I'm looking at everyone's posture in this room, and it's amazing. But it doesn't matter what you're doing as long as you're moving. Going back to what Allison had said, movement is key, and a lot of people feel that if they're moving, they're hurting. And it's usually the opposite. If you're moving, you're not hurting. So here's a snapshot of what your patients might experience when they are potentially referred or seeking chiropractic care. A lot of patients, before I get into this, come to me as a last resort. They're thinking, I've tried everything else, physical therapy hurt me, said, well, you can always try a different one. You just have to find the right one that works. Massage only helps for a day. Oh, acupuncture's scary. I can't even imagine all those needles. So a lot of people come out of desperation of trying everything else. Sometimes ask them, when you tried, what did you try? Was it 5 minutes and then you gave up? Or did you actually give it a good try? So anyway, so chiropractic care, spinal joint mobilization to help restore biomechanical joint alignment and promote healing. So this is not an orthopedic subluxation, a dislocated joint. These are joints that are malpositioned, not moving their full range of motion. The goal of an adjustment is to bring that closer to what is normal. Soft tissue mobilization, working the muscles, tendons, ligaments to enhance the therapy of an adjustment. So in my office, muscles are the boss. If I can't work through your muscles, then what am I going to do to the joints? You have very static joints, and they're there to stabilize your body, but the muscles are the movers. So I really love massage therapy, Emma. Joint mobilization. So there's the spine, which plays into the insurance world. Then there's the rest of your body. Those injuries that are acute and short-term, ankles, wrists, elbows that turn into long-term injuries, chronic mandibular pain, headaches, low back pain, from an injury that, a torn muscle or a sprung ligament, those heal, but the pain resides there later. Sometimes it's not just in your spine. So we do address, as chiropractors, all joints of the body. So rehab exercises. This is where in my office it goes from a passive care, you lay on a table, you get adjusted, you get some soft tissue work done, then you leave. No. In my office, you're gonna get homework. You're going to find a exercise of some sort. It might be, you have a lot of things going on, you need to go over to Allison's office. You really need to be doing more than what we can do in my office today. A lot of patients are pretty motivated by the time they get to my office, and they are willing to try 1 or 2 exercises or a stretch or yoga perhaps. So every care plan is different. We address what their goals are and how we can take that into small pieces and get them on their way. So this can be stabilization, it could be simply posture, it can be yoga stretches. I start with 1 to 3 things and then we build from there. Adjunctive therapy is going back to ultrasound, laser, vibration plates, massage. Some offices offer these in office, some are adjunctive therapies. Nutrition counseling is, everybody gets a comment about water and multivitamins in my office. There's a lot of things that can be covered in an appointment depending on, again, patient-driven goals. If they just simply want to be out of pain, we're going to focus on that. If they have a bit more specific goal of, I want to be able to pick up my toddler without having back spasms, or I want to go skiing again, we really monopolize on what they want to do and break it down into doable steps. A list of things, this boring list of everything that I can treat in my office that is very common. This is just a list of ICD-10 codes. Okay, so goals of treatment, provider expectations. Patients can come in and say, I have 10 out of 10 pain, everything hurts, I can't do anything. And that doesn't help a lot, so taking the subjective versus the objective path, finding out what is the pain generator, what is influencing the pain generator, emotions, histories, traumas, then going from subjective to objective. So taking into account their verbal assessments, their oral pain scales, their patient-specific functional status, activities of daily living, then going into screening tools. If I'm going to be billing an OHP plan, I need to submit the Keel Start Back screening tool. That's a standardized form. The patients fill it out. It comes out to a quantitative number. Jules test, the disability index, Oswestry is a great one. A lot of people are using these because they're just so standardized. They're fairly specific in what you can and can't do. And sometimes patients really feel like, this hasn't helped me. I tried, it didn't work. I just need to go back on my meds. And I can pull out their Oswestry from visit 1 or their Start Back tool and say, well, your Start Back was a 7. Now it's a 2. You have improved. So action plans are patient-driven. And then here is there was one more slide. It's probably on your disk. Bunch of research data. Click the links, read the JAMA articles, and things like that. So, did this work? No? No? Okay. It was the boring research. Okay. Yeah. All right. There you go. Some research and some citations, which says, hey, it's helpful. Insurance pays for it now. Refer some patients in. Get them to try it. And she already told me I was out of time. So, and I like the dancing Merry Melodies skeletons. So.